Mute. Naren.
Yeah.
Naren is unmute.
Unmute, sir.
Today is a unique
Hi,
day.
hi, yes.
Narendra
Yeah.
is muted. देखो.
Narendra, good afternoon. Good welcome. Welcome.
ऐसा कभी
Rotary
होता है क्या
function
नरेंद्र?
going on.
हाँ?
I
नरेंद्र
said
को कोई
Narendra
mute
is
कर
wearing a
दो.
stylish mask.
Nation Builders Award will I.
Arey,
अरे
wonderful.
That's now it is
अरे
getting
वाह.
actually going on.
Naren,
That's why I
welcome.
couldn't pick up.
Welcome,
Thank you.
Narendra. Yeah, welcome.
Hi, Naren.
Thank you,
What
my
is that
pleasure.
medal you're wearing? Medal.
Hi. Abhi
Yes, let's start.
Thank you very
Narendra has
much.
to go for the election now.
PC and
thank you
Naren,
very
please
much.
ना go ना for some
ये बाबा
political post.
हमारा को हमको
PC और
ज्यादा
नरेंद्र
एमपी
को मैं
मांगता है अभी.
I have
तब से मैं
refused.
पीछे
I
पड़ी
know
हूँ.
I had refused.
Foxy has to sponsor the election.
ये अच्छा idea है.
No, sir. It seems like as if you are starting from the grassroots. Both of you so active. We are learning. Today I was telling Purna sir was 5 days back in Hyderabad. Yesterday again in Hyderabad in hybrid. And Naren also, you see, he is in another and coming here for 5 to 10 minutes.
We are bored with hype, the webinar and digital and all that. So I want more of physical. I've started
Absolutely.
from 14th of this month. I've started going outside. I've almost done 6-7 physical meetings.
Oh, that's great. Yeah.
So can we start now?
Yeah.
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 Okay.
Yeah.
Good evening, doctors. Sir, Subhajit sir, you can start.
Yeah. So, good evening, doctors. On behalf of Harmonica Acumentis, I welcome you all and a very happy Teachers' Day to all of you on this auspicious occasion. On the auspicious occasion of Teachers' Day, today is the inauguration of OB-GYN Treasure E-Series by none other than Dr. Tusharkar. And when it is inaugurated at the hands of esteemed teachers like Dr. Narendra Malhotra, Dr. P.C. Mahapatra, Dr. Hema Diwakar, Dr. Rishikesh Pai, and Dr. Pratap Kumar, it assumes significance. It's a privilege absolutely to welcome you all for today's program. And the topic for today's is endometriosis an enigma. In fact, we start with playing the Saraswati Vandana.
Sir, we'll start Saraswati Vandana first.
Yeah.
Not playing.
Not playing, Pratik?
Sir, it's not audible.
No.
It's not audible.
It's audible now, sir.
Thank you. And I take great pleasure in introducing Dr. Tusharkar. Pratik, can we have his say?
Yes, sir. 1 second.
In fact, before I hand over to Dr. Tusharkar for further proceedings, it's a privilege for me to introduce Dr. Tusharkar. Dr. Tusharkar is the chairman ICOG 2019-20, Vice President Foxy 2010, Chairperson Foxy Oncology 2004 to 2009, President AOGO Cuttack 2021, National Corresponding Editor Foxy Journal 2014 to 2016, and Peer Reviewer International Journal of ONG Indian Edition, Executive Committee Member ICOG 2015 to 17, Executive Committee Member IAGE 2015 to 17, Organizing Secretary IAGE Annual Conference 2016, Organizing Chairperson ICOG National Conference 2019, and faculty and resource personnel in many national and international forums. Contributed many chapters in many textbooks and published more than 50 publications in national and international journals. Had authored 2 textbooks, Do's and Don'ts in OB-GYN. He is the recipient of Adarsh Chikitsa Award 2007, Mani Manika Award 2010, Dharandikar Award 2010, Best Medical Publication DC Datta Award 2011, Tarini Pratibha Samman 2015, and Best Original Foxy Journal Publication 2018. So over to Dr. Tusharkar to take over the proceedings.
Good evening to all of you. Guru Brahma, Guru Vishnu, Guru Deva, Maheshwara, Guru Sakshat Param Brahma, Tasmai Sri Gurave Namah. On this occasion, at the outset, auspicious occasion of Teachers' Day, really we are very much privileged to get all of you, especially great figure, great teachers of India in OBGYN, Professor Narendra Malhotra, Professor P.C. Mahapatra, Hema Dibakar, Pratap Kumar, and Rishikesh Pai. You see what a fortunate day for all of us, including me. It is a really very rare occasion in the Teachers' Day where it is considered coincidence. And on this occasion, this forum, that is a web series that OBGYN Treasure e-series, so we are inaugurating, and we are very happy and thankful to all 5 of you for accepting our invitation for this inaugural ceremony or function of this e-series. And all of us know that today's topic is endometriosis an enigma. But before that, for the inauguration, I'll invite, call upon Dr. Narendra Malhotra. Who doesn't know him? So starting from north to south, east to west, outside India, he's a very well-known figure. And especially I must personally thank at this time also, after being president for a long time, President Foxy. He is so active in Foxy. He is an example to all of us, especially to me. So I invite Dr. Narendra Malhotra to inaugurate and say a few words for this e-series.
So a very good evening to all of you. It's indeed a pleasure to be invited to such a prestigious inauguration of such a great CME program, the OBGYN e-series. And I congratulate Dr. Tusharkar for organizing this series and spreading education. And what a lovely day to start, Teachers' Day. Teachers' Day, when to start a teaching program is such an auspicious. So all the best to all of you who are here. All the best to all who will be attending this series. And congratulations, Dr. Tusharkar. Greetings to all the past presidents who are here, Dr. P.C. Mahapatra, Dr. Hema Dibakar, and the incoming president, Dr. Rishikesh Pai, for gracing this occasion to begin this series with endometriosis. Thank you once again for inviting me here. It's indeed a pleasure to inaugurate this. Thank you, Tushar.
Thank you so much, Narendra. You have accepted the invitation and inaugurated as an opening batsman. Next is my own teacher, our own teacher, a teacher of teacher. I can say teacher of teacher, Professor P.C. Mahapatra. Any function in India, in Foxy, if he is not there, it is incomplete, I can say. If his presence means, it is more than enough, and 99% success is there. And he is my teacher for last 4 decades, and will be the teacher till I die. Till I die. So he's a teacher par excellence, and he has started already e-Gurukul. Such a fantastic, such a popular. Every 15 days at this time, he is putting up something for us, for the beginners, starting from beginner till for us also. He's giving some sorts of exercise. And you look at him, so we invited him, and he was yesterday in Foxy FIGO conference in Hyderabad without saying anything. He told Tushar definitely his session is today, that completing 1 year, 6 to 8, again e-Gurukul session. In spite of busy schedule, I told you come for sir 2 minutes, give just inaugurate, and he accepted immediately. Sir, you can say, you can inaugurate this officially the e-series.
Thank you, Tushar, for overestimating me, one of your past teachers, and accepting today also that I'm a teacher of yours. Thank you very much on this auspicious day of a Teacher's Day. It's a unique thing that you have started a wonderful and innovative Treasury series. And I congratulate you from my personal as well as from the different organizations also. As a teachers forum also, I will really congratulate you for continuous program of this. And this not only I inaugurated that gives me an opportunity to meet my friends and my favorites, not physically possible, but digitally possible, right from Hema to Rishi to Pratap Kumar to Narendra. I think it's a great pleasure to see all of you. And before the academic scenario will start, and Tushar, you are wonderful. I know I have assessed you long before when you were a student and then a faculty of yours and a colleague of mine. You have participated in all that. You can do wonders, both in terms of teaching as well as you are a loyal Foxians. I think for Foxy activities also, you are an asset to the Foxy, an asset to the teaching forum all over India. And that's why I said that, yes, this is a good initiative on a very auspicious day of a Teacher's Day. I wish you all success and continue in life for all aspects of that, and really feel that this particular program will be really a successful program, an ongoing program, not only for the students, but for the practitioners overall and all gynecologists across the country. Thank you very much.
Sir, thank you. As a teacher, you told, but as a student, I'll tell one thing, sir, that you remember from postgraduate days, you have never left me. All the time you have groomed me, like keeping me in all unit, from the lecturer till associate professor, you have kept me all the time, sir. And till now also, I feel that you are no more, you are still there with us.
Thank
Still
you.
there, sir.
You are with me. You are in my heart. You are in my heart.
Sir, reverse way, being HOD also, thinking you that you are the HOD and I am the executive HOD. Always, sir.
You are my heart always. You
why I am, sir, why I tell so? Because in difficult time also, I remember, oh, sir solves in this way the matters. Not only academics, practical thing, everything, sir.
Thank
you very much, sir,
for
inaugurating and coming, sir, in spite of your busy schedule. And definitely I'll join after 6 to your program, sir.
Thank you. Thank you.
So next I call upon Hema. Who doesn't know Hema? She is my sister, Foxy's sister and daughter. You see, whenever Hema comes, means again, we become light. We become light, so much mobile and all at this time also. So she was the past president. Till now, she is so active and she has contributed so much to the society, not only to OBGYN, but public of India through Manyata. So if Manyata in India means it is Hema Dibakar. So I thought that, no, we must call upon Hema to inaugurate so that it will be famous or it will be popular amongst the practitioner, at least view of clinical practice. Now I invite Professor Hema Dibakar to inaugurate officially.
Namaskar. Thank you, Tushar. The very opening remarks that you made and the follow-up on your thoughts about PC Sir, as many fondly call him. PC was just talking about connect and connections. Yes, these are the Wi-Fi connections. We know, but the connect that we have, the emotional connect, the instant joy and the thrill that we and the moral courage in a very strange way that we encourage each other by our very presence is something that is to be experienced rather than spoken about. And you have rightly called this series as treasure, because when COVID has taught us health is wealth, wealth is something that people think it's treasure. Okay, so we know that knowledge is treasure, knowledge is power for us. The same way as you said, the teachers may come and go, but the teachings will always stay. And that is how you have addressed PC and all the other distinguished guests whom you have called for the inaugural ceremony. All of them have a large heart and the right intent of doing their bit and whatever best they can do. We have Narendra, which name itself is symbolic of Narendranath from Vivekananda times, that you would know, Narendra Modi from Modi ji, and we have Narendra Malhotra in our Foxy. So that is how it is. And Purna Chandra, anything that is half becomes full when Purna comes in, and Maha is like Maha, like a Mahatma, Mahapatra. That Patra is the role that he plays, and you have rightly commented, Purnachandra. And as far as Rishi and myself are concerned, we are the kids from the same block. When you said Manyata, I'm the mirror image of Rishikesh Pai, because we are like two sides of the same coin, as Sarvapalli Radhakrishna, whose birthday we are celebrating as Teachers' Day, said art and science are two sides of the same coin. I have been very, very deeply impressed by Radhakrishna's writings, because that is what we started an initiative called Avishkar, discovery through performing arts and science. The science and arts can never disintegrate or segregate. And so I can speak about Rishi and myself that we are like one unit trying to do things together with some synergy to expand, amplify, and excel. And what I learned from Dr. Pratap Kumar was not just the teaching. I have been with him at Manipal and stayed over at his house also. And the hospitality, the compassion, the kindness, the softness, the communications, the way we have to deal with people of all cadres. So everyone has a strength in themselves. And I'm so very grateful that even in the Saraswati Vandana, it said, Yakunendu Tushara Haradavala. Now you are there now everywhere, Tushar. Now you have to just really make things good and big. And we are all there all the time. And we are just a message away or a phone call away. And we will pledge to do our bit to see to it that the treasure that you treasure so much, starting today, will continue forever and forever with a sea of the brilliant deliberators who will exchange their experiences beyond the textbook knowledge. So Subhojit and team, thank you for your support. And Tushar, thanks for your kind invitation. And it was indeed a pleasure to see all my fellow colleagues, very beloved and very inspiring in their own merit. Thank you.
Thank you. Thank you. Really, Hema, you have told rightly with one phone. All the five of you have responded positively. It speaks of the wavelength, same wavelength with all of us. But at the same time, I can say you are one of the team members who could identify this OBGYN Treasure E-series. Actually, you have correctly pointed out that the treasure, many things we are doing, but for the OBGYN, for academics, this is for us treasure. And the second thing, you have correctly told that whenever 4 to 5 people, the output is maximum instead of one man. So I discussed with my wife, she is Sarantip, HOD pathology. So what would be the best name? And I discussed with many, went to Google and all everything, what would be the best for the practitioner as well as postgraduate. And you are the person who have pointed out correctly that treasure is a fitting word for us this. And with this, thank you very much, Hema, for attending. You are busy yesterday, I know. And in spite of that, you say, okay, go on. Thank you. Now coming to Rishikesh, my good friend Pratap, I'll be coming because you see, you will be the
Tushar, please call Pratap first. He's like my professor, so I can't talk before him.
No.
Very nice, very nice. Okay, because because Pratap, you see, immediately without telling anything, he told me, Tushar, okay, no problem, go on and tell me what is the thing. You see, it's like same wavelength speaking in the same forum with the same topic. So who doesn't know Pratap Kumar? He is a figure in India, not only India, Southeast Asia, everybody knows, Malaysia to Pakistan to Sri Lanka. So he is the full of academics. Any question, anywhere, any topic, not only as a postgraduate, but as a clinician, being an educationist or a faculty also, whenever I ask anything, he answer. You see, he's a ready-made dictionary, medical dictionary. So I invite Professor Pratap Kumar to just formally inaugurate this e-series.
Very good evening to all of you. Thank you, Tushar, for inviting me to be a part of this inaugural ceremony on the Teachers' Day. I have been teaching for the last 40 years at Manipal, and I'm still in the medical college. And I just head the reproductive medicine and surgery department rather than obstetrics and gynecology now. And my teaching has been a passion. And I think, as Tushar, it's a really great plan for having done this e-series supported by Acumentis, Harmonica, Subhajit, and Pratik. And so nice to see all my friends on this online platform. And as you said about teaching, and it's a great achievement for anybody. And when Rishikesh Pai said, I'm not your professor, Rishi, but I'm your friend. But I have a great respect for you because you're the next President Foxy, and I'm sure you're going to have a lot more series in your mind to teach people. And Tushar, once again, thank you so much. Wish you all the best for this series, which is going to be successful. I can make out a lot of people have already logged in, and I think it's going to be a great achievement for you. Thank you so much, Tushar, and a pleasure meeting all of you.
Thank you, Pratap, for your spontaneous agreeing to inaugurate this session, this series. At the same time, I must tell that whenever I see your face, even either physically or by this in the website, I feel that yes, I am in the classroom or we are in the board meeting like that for some academics. Thank you. Once you come in, with your presence, you see our doubles of the academics.
Thank you, sir.
Very much. Now, next is, you see, Rishikesh. He's so friendly, so young, dynamic, president-elect. So your presence has really, you see, enlightened. Rather, it has doubled the happiness of our e-series inauguration. So who doesn't know Rishikesh? He's an infertility specialist. He's a very good human being. The most important, very good human being. In crisis, in happiness, he is there. Where at the dead of the night you ring, he will suggest something. So he is close friend of all of us, and you see he's liked by all. So now I call upon Rishikesh to say a few words for the inaugural session of this.
And moreover, Rishikesh is, I think half of his home is Cuttack.
Yeah. That's what I was going to tell. Thank you, Tushar, for calling me. They are all my very close friends. I'm really amazed that you brought these people together. As Hima said, all of us have taken hospitality of Pratap. I've stayed with PC also. I remember one of my first talks in my career was in Agra in 1991. I stayed in Narendra Malhotra's house also. Next time when I'm in Bangalore, I'm going to stay in Hima's house, so that will complete the circle of everyone. So what I'm saying is that they are all like, I told you Pratap Kumar is like a president of Foxy. It's just that he doesn't have a designation, but his stature is like, I would say that all of these people who are sitting here, all the four of them can become FIGO president. So these are such statures. Unfortunately, it is a pyramid, so not everyone can become, but doesn't mean anything to us because it's not the position. It is the how you exist. Existence is very important in life. You understand? It's not a position. So but I suppose you realize that after you reach a position. When you reach a position, you realize that the position has no value and your existence is more valuable than the position. Just like PC said now about connect and connection. So I think, like in IVF now, for example, natural cycle IVF is, it is only possible after you do many normal conventional IVF. When you do a lot of eggs and then you can understand that one single embryo formation is more powerful than multiple embryo formation. So it is, all for one and one for all kind of concept, So I feel that just, and you are also a great human being. You are always smiling and wish you the very best. And there are two types of people whom we have to teach. So one is the student. Of course, students have to study a lot and they have to pass the exams and all the professors are there. So one of my wishes, and they are all here. All the two great professors are here. PC is there. Pratap is there. You are there. So and Malhotra is there. Malhotra Narendra is there. So my wish is that we must standardize the, miss, what I feel now is that when you create a student, see, there are medicine, there are two types of people you create. One is the inventor who creates the next thing, who is a great operator, who does research. So you need that hierarchy, but more important than the hierarchy, you need the standardized provider. See, the medicine is not invention. Medicine is provision. Medicine in India is to provide service. So what I feel, and when I look back, I feel that this service provision is defective, because the people who are coming out at our PG level, suppose you ask some PG to ask, okay, there is a fever in pregnancy, how will you treat it? Different PGs will say it differently. So my fervent wish to all the great professors is that maybe in the next year when I become president, we can have a 5 days or a 10-day meeting, and we create symptomata, we create a synergy that every MD person, if you ask him, he will give the same answer, same protocol, same algorithm. He cannot change the algorithm. That can be, if that can be achieved, we'll have uniformity in application, because that is a primary aim of medicine. You have to create a doctor who will uniformly apply the medicine. So I would suggest that we create a book. If that book is, if the PG person, there's a question and an answer, he gives the answer which is written in the book, he should pass the exam. So there should be two tables. One should be for passing the exam. We want to create a service provider. We don't want to create an inventor. We don't want to create a great surgeon, great laparoscopic surgeon. We don't want to create a vaginal surgeon, great. We want to create an average doctor who will provide the same medicine. The second table should be the inventor table. There, Dr. Pratap Kumar can ask, okay, tell me what is the publication which you read 2 months back? And he can talk about odds ratios, etc. That will create the hierarchy. That will create the selection of the lecturer. That will create the inventor who will invent things. We need that also to create progress in medicine. So that is a secondary part. What is happening is we have mixed the two parts. We have mixed the provider with the inventor. So what has happened? There is chaos. We have a totally chaotic medicine. I'll just leave this by one last observation. My own secretary in Chandigarh, her father got a pain in the epigastrium at 5 o'clock in the evening in Chandigarh. He went to a general practitioner. He gave her an antacid and said, no, it's acidity. He sent him back. At 8 o'clock, again, he went to another doctor. Again, he said, no, it's an antacid he gave. And he died at 11 o'clock in the night in Chandigarh, which is one of the advanced centers of medicine in India, because he had a heart attack, because the symptomatology was not taught. Everyone is taught differently. So I am very ashamed of this medical system of this country, because it doesn't tell you consistency. They will tell you malaria's life cycle. This malaria organism goes to this liver cell. Who is bothered about all this crap? We want to know what is the two types of malaria. A dangerous malaria called falciparum and a simple malaria called vivax. And what is the treatment for the two? We want it in 2 minutes, because that can save a patient. That is not taught by our professors. They teach the life cycle of malaria, so that when you reproduce it. So one of the things I want to create, and this is all for you professors, we need to create the app. So if there is a symptom, he should refer to the app, and that app should tell him what is the exact algorithm. That is what I would challenge you to create, Tushar. Create the app. And we will implement it. So let us integrate medicine in the future. Let us not, what is the use of doing all these big lectures? Has it already relevant? Because our medical graduate is supposed to provide care. And a uniform care. Anyway, this is my philosophy of thinking.
So Tushar, you create the app, Rishi will implement, and everybody will treasure it.
So we need to be systematic. We don't want to have research. Who's bothered about what research? We want to save that person who gets a heart attack.
Yeah.
That is what is our role. Primary role.
Rishi, it's a 22nd century thought. Brilliant, innovative.
Thank
It's
you.
not 21st century, but 22nd century.
Thank you.
Sir,
Thank you very much for calling me.
No, thank you. Thank you, Rishikesh. You spoke so nicely. You are a very spontaneous one, and which you have thought really, that is the practical thing. Ultimately, people are asking, sir, what for reading? So get rid of the fever, get rid of the heart attack treatment. So actually, you are correct. So they want the result. So and result, it should be the education should be result oriented, medical education. So thank you very much, Rishikesh. At the same time, sir, especially my special thanks to Purna sir. In spite of his busy schedule, at this time also he has agreed and he has come upon, and also Narendra, then our Hema, Pratap Kumar, Rishikesh, all five of you. In spite of busy schedule, you have come, and I'm so much delighted. Almost you see inauguration session and a Teachers Day. I am really indebted to you, and I am really very happy, and I cannot but express in which way I am indebted to you. So at the same time, and keep us uplifting for the academics as well as the patient care, which is the prime. Thank you very much, sir.
Thank you. Namaskar.
Thank you.
Thank you.
Bye
Namaskar.
bye.
Bye-bye.
All the
Thank you.
best.
Thank you very
All
much.
the best,
Bye,
sir.
Subhajit.
Thank you.
Thank you.
Happy
Thank you,
Teachers
sir.
Day to all of you, sir.
Happy
Once
Thank
Teachers
again.
you.
Day. Bye.
Tushar,
Bye,
all the
PC.
best
Bye,
once
Emma.
again.
Bye, Narendra. Narendra must be busy delivering someone.
Yeah, he was telling me he has been 3, not deliveries, but 3 other webinars. Yeah.
Acha, okay.
Bye-bye.
Okay,
All
Pratap,
the best.
bye.
Bye-bye, Rishi,
Bye, bye,
Hema,
Pratik.
Yeah. Bye, sir.
Tushar, Subhajit, Pratik.
Bye. Thank you.
Bye,
Thank
PC,
you.
Narendra.
Thank
Bye-bye.
you very much. Okay, Pratap.
Bye-bye.
Okay, bye. Bye. So, just
So now you will continue with this, right, sir?
yeah. So I'll be share screen. I'll be continuing. Just give me 1 minute. Just I'm
Yeah.
sharing
Yes, sir.
my slides PPT. तो फिर ये करिए पूछूं
Yes, sir. It's visible.
Is it shared?
Yes, sir. It's visible. Sir.
Okay, visible. Okay. Am I audible? Yeah. Should I start?
Yeah,
Yes, sir.
you're
You can
audible.
start.
Guru Brahma, Guru Vishnu, Guru Deva, Maheshwara, Guru Sakshat Param Brahma, Tasmai Sri Gurave Namah. With this, on this auspicious occasion, this series, all of you know that this is OBGYN. So what is our intention? The intention is to target the audience like our postgraduate and the practitioners in OBGYN. So we'll be having which will cover up a topic which is of clinical as well as the basic practitioners places of India can be benefited. So I thought that let me start with the first topic, which is very much important in our day-to-day practice, that is endometriosis, not only for a practitioner, but also for a postgraduate. Either you get long case, short case, specimen are there, and many more things are learning, and what is the update for that only I have come, and it is a disease, this is an enigmatic disease. So therefore, I selected this on the inaugural session. So greetings from Jagannath. You see, this is our SCB Medical College, Cuttack, where our from the faculties with the Department of Obstetric Gynecology, and this is from the message from the dedicated COVID obstetric hospital from our department. So with this, let us come to the definition of the endometriosis. As an undergraduate, as a postgraduate, as well as a clinician, we know that endometriosis is defined as presence of endometrial tissue outside the endometrial cavity. So this can be either in the uterus, where it is known as adenomyosis, or outside the uterus, that is known as endometriosis externa. All of you know that the sites may be at very places, but roughly the endometriosis is the presence of ectopic endometrium. So what do you mean by ectopic endometrium? That is stroma and the gland. Both components must be present there. But it is told that by Henry Ford, anyone who stops learning is old, whether at 20 or 80. Anyone keeps learning stays young. So if you keep this definition long years back, almost 4 decades, that the same definition persists. So is there any changing in the understanding of the endometriosis? So we have to think of that. Is it time to redefine the endometriosis? That why there is only endometrial and epithelial cell and stromal cell in ectopic site? That is the constant or the conventional definition so far. That means endometrial epithelial cells and stromal cell both should be present to define an endometriosis. So whether it is correct or not, let us see that. So before that, we must know that we are seeing some fibrotic tissue in the histopathology of the endometriotic cells. So in addition to the stroma and the gland, the fibrotic tissue are present in certain endometriotic tissues, like in the endometriosis of the rectovaginal pouch of peritoneum. No stroma, no gland is there, only fibrotic tissue. So therefore, the recent definition, why we should redefine? So because we are finding certain fibrotic tissue in certain endometriotic site. So is it the time to redefine? So therefore, the third definition, third component of endometriosis is coming, the presence of the fibrotic tissue or fibrous tissue. So therefore, in presence of that, we can redefine that stroma, gland or fibrotic tissue outside the endometrial cavity is known as endometriosis in the modern. This is not yet accepted, but perhaps this should be the future definition of the endometriosis. Now, what is the prevalence? That the prevalence is actually happens because of the delayed marriage, that is in true sense or real sense, and postponement of the first conception and of the small family love. That means whenever some pathological condition, instead of physiological, what is the physiological? That the couple should marry around a girl 21, 22 years, after 18 years, she should be pregnant 21, 22 at the ripe age. Not the pregnancy should not be delayed. She should have normal family. If it is a small family, no one child, no child, and these are the real cause of the, you see, endometriosis. And what is the apparent? Because of the more of diagnostic labs, especially in the infertility, we are accidentally diagnosing endometriosis. And awareness amongst the doctors that yes, there is a disease called endometriosis where it is externally not visible, but only when you do a laparoscope, you can see that. Perhaps because of the apparent cause, the prevalence is increased. And prevalence is around 10% amongst all the gynecological disease. In infertile women, the incidence is around 32%. That is really whether the endometriosis is associated with infertility or infertility is associated with the endometriosis. But whatever it may be, it is a vice versa. In the sense, if there is an infertile woman, there is chance of 30 to 40% of the endometriosis. In a reverse way, if endometriosis is there, it causes infertility almost 30 to 40%. Now, what are these sites? These can be abdominal, extra-abdominal like scar endometriosis, umbilical endometriosis, episiotomy wound endometriosis, cervical endometriosis, or vaginal endometriosis. Many of you might be seeing one or two cases of scar endometriosis or umbilical endometriosis, or even a scar after the hysterectomy, after the cesarean section, and a remote area outside the abdominal cavity, like in the thighs, arms, or in the lungs, the endometriosis is possible. Now, what are the common sites? Are the ovaries, pelvic peritoneum, pouch of Douglas, uterosacral ligaments, rectovaginal septum, sigmoid colon, appendix, pelvic lymph nodes, and fallopian tubes. If you see, out of all these things, most commonly we find a chocolate cyst that is in the ovaries. Pelvic peritoneum, lateral pelvic wall, you can see. Uterosacral ligament, rectovaginal septum nodule, and sigmoid colon. But very rare in the remote site. As I have told earlier, it can be in the umbilicus, abdominal scar area, or episiotomy wound, lungs, pleura, ureter, kidney, that means any urinary system, even in the arms, legs, and nasal mucosa. So it is possible to see endometriosis very rarely in those sites. Now, if you see, out of all these things, the commonest here in the picture is the ovary. Next to ovary, that is the lateral pelvic or pelvic peritoneum. Then is the uterosacral and rectovaginal septum or nodule. This is the endometriotic nodule. So out of these, we should be careful for the any localization of endometriosis in the ovary. Now, the risk factor of the endometriosis, if you see that because of the low parity, I have told, there is an inadequate of family norm, like let us say instead of 2 or 3, it is 1 or less than 1. So there is chance of endometriosis. Delayed childbearing, she is married for 4 to 5 years, knowingly she has planned for a delayed pregnancy. So this is the time, this is the initiation period where endometriosis can occur. And family history of endometriosis in 17 countries, it has been studied and proved that it runs in the families, like sister suffer, like mother suffer, means the daughter is likely to suffer for endometriosis. Now, genital tract obstruction, like imperforate hymen, that is upper third of the vagina is obliterated. And environmental toxin like dioxin can cause endometriosis. You must remember as a postgraduate. Now, molecular defects could be there either in the form of cytokines, tumor necrosis factor, that is alpha TNF is a factor for this endometriosis, and presence of the macrophages can precipitate the endometriosis, and matrix metalloproteinase is also a factor for endometriosis. Besides that, other molecular factors like interleukin 1, that is IL-1, vascular endothelial growth factor VEGF, and estrogen, all these things can attribute to the development of the endometriosis, or all these are the risk factor for the endometriosis. Now, coming to the pathogenesis, it is a enigmatic disease. So, per se, starting from the definition, from the pathogenesis till pathology, diagnosis and management, all are enigmatic. So therefore, coming to the pathogenesis, not a single cause has been proved. Now, starting from the Samson theory, what is that? Retrograde menstruation. Now, it has been for years together, for last 4 decades, it has been taught that the retrograde flow of the menstruation can precipitate the endometriosis anywhere. And you can see the main cause or analysis for understanding the development of the endometriosis in the ovary in the form of chocolate cyst, lateral pelvic wall, all these things can be contributed by the Samson theory, that is retrograde menstruation by any means, whether there is an outlet obstruction or during menstrual normal due to pressure, intrauterine pressure, some of the endometrial tissue, including the RBC, is going back and sits on the ovary or other surfaces, may lead to this endometriotic development. Then coelomic metaplasia, as told by Mayer and Ivanov, in the process of development, that can be some metaplastic cell and remain on the tract of the development. Though direct implantation, the endometrial tissue goes by any means during the cesarean section. During the myomectomy, it can sit upon and develop further afterward the endometriosis. Lymphatic theory, that is known as Halban theory. So by lymphatic through endometrial tissue goes and embed somewhere. It is known as a lymphatic theory. Then is the vascular theory, that is through the vessels of the mother. These endometrial tissue can transfer from some place, uterine cavity, to the other. And the most upcoming theory is the genetic and immunological theory, about which that molecular theory I have told, starting from cytokine to VEGF, all are responsible forming the macrophages and later on to the endometriosis. And last is environmental theory. But I'll add on what to it. Perhaps in addition to that, the inorganic food, in the recent, the adulteration of the food and the environmental pollution, and therefore leading to the change in the lifestyle might be one of the factor, though the book doesn't describe till now. Perhaps the change of the lifestyle for the modern girls, especially those BGIT people, may lead to endometriosis. So coming to the sites, I have told that in the pelvic endometriosis could be in the pelvic peritoneum. This can be, pelvic endometriosis can be understood or can be explained by the theory, that is retrograde menstruation. Now pelvic peritoneum, how it occurs? Endometriosis by the coelomic metaplasia. In the development of the female genital tract, some of the endometrial tissue might stay on the tract of the development of the genital tract. Now abdominal viscera, rectovaginal septum and umbilicus, all the endometric site can be explained again by the coelomic metaplasia. In the abdominal scar endometriosis, episiotomy scar endometriosis, vagina, cervix, lymph nodes and distant sites like lungs, pleura, skin, lymph nodes and nerves cannot be explained by the retrograde menstruation. So this can be explained by either direct implantation, like I have told during surgery. Scar endometriosis can be explained, lymphatic spread, distant site can be explained, and vascular spread, genetic and immunological. So therefore, friends, till now the pathogenesis is not clear so far. What is the cause, exact cause of the pathogenesis of the endometriosis? Perhaps all these theory have explained so far from our undergraduate days, we have been knowing, but only importance is of molecular biology for the development of the endometriosis. Perhaps that one is the only accepted one so far. Now coming to the etiopathogenesis, perhaps the genetic mutation is one of the factor which contributes for the endometriosis. You can say that in the same family, mother is suffering from endometriosis. There are two daughters. One daughter is having endometriosis, the other daughter is not having endometriosis. So this can explain by the genetic mutation. And immunological, as you know, immunological, the patient is compromised, the woman is compromised, the girl is compromised, and molecular defects, certain molecular defects are there, and it is established that mechanical outflow obstruction, or right in the form of imperforate hymen. We have seen many cases of chocolate cyst. Whenever there is an imperforate hymen or some of the congenital structural defect of the female genital tract, like upper one-third non-canalization of the vagina, in those cases we are seeing that chocolate cyst incidence is more. So these four can explain in a better way than that of the conventional theory for pathogenesis of the endometriosis. Now coming to the pathology, you see, we must know that I told that is presence of the glands and the stroma, that is known as ectopic endometrium. So endometrium, it shows glands and stroma outside the endometrial cavity on histopathology, we call it as endometriosis. So there can be proliferative changes, cyclic growth and shedding, but the blood cannot go out. So therefore it becomes irritant, causes dense reaction, forming macrophages. So later on it encysted and forms chocolate cyst in the ovary or hemorrhagic cyst. And in the fallopian tubes, very peculiarly in endometriosis, either it is an external or an adenomyosis, these are patent. These are not invariably, if you give a dye test in infertility with endometriosis, you see that both the fallopian tubes free spillage on both sides. So that is a peculiarity, and inside, that is endosalpinx, are not yet affected, very, very rarely affected by the endometriosis. Now, naked eye appearance, what it shows endometriotic lesion, that you can see in the laparoscope. We say that the laparoscope is the gold standard for the diagnosis of endometriosis. So on the laparoscope finding, we see powder bone appearance, you can see matchstick appearance, or jelly, that is endometriotic jellies. So friends, you believe me, if you see either of three, out of three, any one, you can tell that yes, it is a case of endometriosis. But documentation is there for practitioner. You have to have a document with the video. Then only you can say, suppose I say that you are having powder bone appearance, yesterday I did a laparoscopy, but no documentation. On the microscopic appearance, that is hemosiderin laden particles. Why it happens? Because encysted capsule, encysted cyst, there is RBC accumulation. These are degraded, and hemosiderin are accumulated and gives the laden particles, like that hemosiderin laden particle we call it. Now, for the diagnosis, you see, out of all the diagnoses, the endometrial biopsy by the immunohistochemistry. So you diagnose the tissue from the endometrium, you do a DNC. In a case of suspected case of adenomyosis, we have known that the diagnosis of adenomyosis confirmation is by histopathology. For histopathology, earlier we have to do a hysterectomy. Unless you do a hysterectomy, you cannot diagnose. But today, there is a time where you take a tissue, endometrial tissue by DNC. In a case of adenomyosis, suspected case of adenomyosis, you subject for a PGP 9.5 antibody by immunohistochemistry, and the detection of nerve fibers by immunohistochemistry in endometrium or endometrial lesion could be taken as a novel marker, and thus it could replace the histopathology study of hysterectomy and resection specimen as the definite modality of investigation for endometriosis. Perhaps this will be the upcoming diagnosis for adenomyosis and endometriosis. So what we do, we take a endometrial tissue. This is our own study also in SCB Medical College, Cuttack. Myself and Dr. Sarantikar did this 2 years back. We took samples from the suspected case of endometriosis. We subjected for immunohistochemistry for 9.5 antibody. Then we saw that those are corroborated with the histopathology finding after the operation or a hysterectomy on adenomyosis. And it was proved that yes, these are the cases. Perhaps in future we will focus toward the diagnosis of the adenomyosis. Now, what are the clinical features of the endometriosis? The patient profile is quite young. That is the peculiarity. You see, nowadays, if you see our own series, in every day in our Sushti hospital, almost 50% of the cases I am dealing with the endometriosis, especially surgical. Let it be a hysterectomy case, let it be infertility case. You see the increased incidence of the endometriosis. Now, either you can see that minimal or mild symptom might be there, a moderate symptom might be there, or severely or deeply infiltrating symptom might be there. But out of all these things, you see, in certain cases, you are asymptomatic. So that is the peculiarity of this disease. Now, coming to the symptoms, I told the majority of the cases are asymptomatic. So therefore, the young girls having dysmenorrhea, they present to us and having problem. They cannot say that I am having dysmenorrhea or something else, or pain in the abdomen. But while examination on accidental finding investigation for infertility case, you find a endometriotic lesion. And symptoms not related to extent. The peculiarity is that suppose there is a mild subchalasis, but severe pain is there. And that is severe pain, you do not know, but rectovaginal septum nodule is a big one. So therefore, friends, symptom is not related to the extent of the lesion or depth of the lesion. Now, the depth of penetration is very important to create a symptom. So therefore, there is no measurement except imaging in the form of MRI to say that the depth of the lesion is quite inside or quite depth, and it can give a severe type of symptom. Now, non-pigmented lesion is more painful than the pigmented, like endometric jelly or powder bone or mastic appearance. These are less painful than that of the deep infiltrating rectovaginal nodule. Now, symptoms related to the site again. In the ovary, pain might be less, but in the rectovaginal area, lateral pelvic wall, if it sits, the pain might be more. Degree of pain, that is severity of endometriosis. So if the more the severe, that is grade 3 and 4, pain is more. Now, coming to the symptoms, that dysmenorrhea, which are the three triad, that dysmenorrhea, dyspareunia, and infertility are the three triad of symptoms for endometriosis. Remember, friends, it is the dysmenorrhea, dyspareunia, and infertility. So coming to the dysmenorrhea, it accounts for around 70% of the endometriosis, and abnormal uterine bleeding only 20% in the form of abnormal uterine scanty flow, menorrhagia, AUB, and infertility. Look at it, 40 to 60% I have told, and dyspareunia around 20 to 40%, and CPP, chronic pelvic pain. If you have excluded all the causes, you think that perhaps it is the endometriosis that is the cause of the pain. Now, the causes of the pain, how the pain is caused in endometriosis. Perhaps the PGE cytokines are released. This is because of peritoneal inflammation. These cells, the endometric cells, irritate the peritoneum and it forms the macrophages, and therefore from that lesion PGE cytokines are released, and tissue necrosis, then adhesion formation is there, and nerve irritation. Once nerve irritate, it causes pains and release of local inflammatory mediators, endometrioma formation. So therefore, when nerve is irritated, pain occurs. When local inflammation is there, then gradually the endometriotic lesion is formed. So we know the causes of the pain, and other symptoms, like there might be urinary symptoms in the form of dysuria, that is painful micturition, that is hematuria, polyuria, at times retention of urine if the lesion has involved the bladder. When it involves the sigmoid colon and rectum, there is chance of dysphagia, that is difficulty in defecation, there is chance of bleeding per rectum, which is very rare, but that is chronic fatigue, also it is very rare, and if the lungs is involved, there might be hemoptysis. And if it is surgical scar, we have seen that CS scar site endometriosis. What happens? Only during menstruation, there is pain in that site and that is swelling. Recently, I have done an exercise scar endometriosis of a previous cesarean one of the angle. I saw that only during menstruation, there is increase of the growth, she is telling, and there is pain during that site. And that is the diagnostic. After doing an ultrasound, you diagnose and you go for the excision of that lesion. Now coming to the sign, what you see after the symptoms, you examine the patient, you go for a general examination. Usually on the general examination, in addition to if it is a infertility case, you see the sign, you examine in the line of infertility. But additionally, on the general examination, you do not find anything in a case of endometriosis. But coming to the per-abdominal examination, if the endometriotic cyst or chocolate cyst of the ovary is quite big one, 14 weeks, 16 weeks, then, and is usually lateral, you can feel that. Otherwise, again, small chocolate cyst, orange size, large lemon size, they are not palpable per abdominal. But coming to the pelvic examination, on the local examination, if there is a vaginal nodule, episiotomy nodule, then only you can see. Otherwise, you cannot see. But you can do a per speculum examination. It is seen that in a nulliparous woman also, whenever you put the speculum, no finding is there. But perhaps in few cases, you find associated cervical erosion. Why so? Because we know that the endometriosis is an estrogenic condition. If you give excess amount of estrogen, there is chance of erosion. Perhaps that is the cause. Even without that delivery, even prior to delivery, in a nulliparous woman, if endometriosis is there, we find an associated cervical erosion. And if you do a PR examination, for rectal examination, in certain cases, if rectovaginal nodule or rectovaginal endometriosis is involved, then you find a nodule in the pouch of Douglas. Then here is a question: how do you differentiate from the grade 4 ovarian carcinoma or advanced ovarian cancer, where pouch of Douglas nodule might be there? That is a diagnostic of the ovarian cancer. But here those are fixed one. These are in the pouch of Douglas, but here you can see in the vagina to rectum, that is in the abdominal cavity. But in endometriosis, a rectum to vagina or vagina to rectum, but that is above that in case of ovarian cancer. Now, how do you diagnose that? We know from the history it is a progressive disease. It is having a dysmenorrhea, dyspareunia, infertility, which I have told. On post-speculum, bluish, powder-borne appearance might be there in the cervix, and on bimanual examination, nodularity in the pouch of Douglas, which I have told. But remember, if there is lateral pelvic wall extension of the endometriotic lesion like grade 3, grade 4, there is restriction in the movement of the uterus. Now, coming to the biomarker or serum markers in the endometriosis. After this, you have to take the blood sample and investigate. We know that commonest biomarker is serum CA-125. But friends, you remember, it is not a diagnostic biomarker for endometriosis. So we know that it is a therapeutic response. Only for a therapeutic response is a prognostic marker. And monocyte chemotactic protein 1 might be the future tumor marker for the endometriosis. So therefore, friends, you remember, it is never a diagnostic one. It is for a therapeutic. The patient has received treatment. Now, after 6 months, you want to reassess. You take the again CA.
Hello, Tushar sir.
His audio is not coming, no?
हाँ sir, there must be some network issue.
Yeah.
Wait, I will call soon.
Just call it.
Is it coming now?
No, your voice is audible. Your
Yeah.
videos.
Video coming now?
No.
Not coming. Okay. I'm stop video and then again. Okay, it's coming now.
No sir.
How it is not shared? Hello.
Sir,
Yeah.
your voice is audible. Your video
Voice
not.
is audible.
Yeah. Voice. I am audible.
Yeah.
Yes
Voice
sir,
is
you are audible sir.
Video is on. I am making it. You see, I am unlimited, but video I make it. Is it coming now?
Yes
Yeah,
sir, it's fine.
yeah. Your
Video is okay.
now you can share.
Okay. So biomarker you can just close it. Okay. So the upcoming biomarker is the monocyte chemotactic protein, that is MCP1. It's not moving. It is not moving.
Sir, please share the screen.
Okay. Share the screen. Dakilo. Okay. It's not shared, na?
हाँ sir.
No.
Even sir, your video is also free.
Okay. But everything is all right. Other is not shared, huh? Okay, just give me time 1 minute. Is it shared now?
No.
Okay. Just I'm working on it.
Sir, is there any network issue?
I'm seeing that. I'm seeing that actually there might be network little bit. It na. You can switch over to other. Okay.
Audience, I'll just request to stay on for some time, just
Connected. If
minute
there
or
is no
so.
network, there is some network problem. That's all. So I'm working.
Sir, please unmute. Yes, sir.
Yes, screen is shared now.
Sir, you have to share this screen.
No, we are sharing it.
Yeah, now it's visible, sir.
Yeah,
Am I audible? Am I
yeah,
audible?
yeah,
Yes.
yeah, yeah, yeah.
Okay, it's shared now. Okay. So yeah. You see the recent marker is the, you see, marker is the monocyte chemotactic protein I was telling, MCPP1, which will be the coming one, and it will be the diagnostic serum marker for the endometriosis. Now coming to the imaging, you see starting from the ultrasound and especially the transvaginal sonography is one of the or the commonest modality. But in certain cases, we may take help of the MRI, CT scan, colonoscopy, rectosigmoidoscopy, and cystoscopy. But out of which the ultrasound, especially TVS with the Doppler, is one of the common modalities of imaging. In rare cases, we are going for the MRI or CT scan to map the lesion of the endometriosis. Now coming to the laparoscopy in endometriosis, as you know, I have told the laparoscopy is the gold standard in the diagnosis of the endometriosis. So it has got a lot of benefits in the form of mainly magnification. So without tactile sensation, it can magnify up to 10 times than that of the normal. And the benefits other, like we can see the site, exact site, size you can extend, just calculate and extend of the lesion. We can take a biopsy through the laparoscope. We can stage by the laparoscope. Extent can be recorded, and simultaneously therapeutic surgery. You can infiltrate something, and if required, we can go for a therapeutic surgery, cystectomy or oophorectomy or lesion. We can char the powder bone appearance of the endometric lesion or mastic appearance. Jelly can be fulgurated, and powder bone mastic appearance. They are the diagnostic feature in case of a laparoscopy. But only thing is the laparoscope that we cannot have a tactile sensation. We cannot measure the extent or the depth of the endometric lesion, especially in the rectovaginal septum or a nodule. Now, this is a Kamran Nijat has a lot of work on the endometriosis. He is a famous laparoscopic surgeon from US, and you see he is famous. His name is famous, especially in view of the endometriotic work and in the form of laparoscope. Now, coming to the differential diagnosis, that in endometriosis we can get the other disease. We may confuse with the other disease like chronic pelvic infection, benign ovarian tumor like epithelial group of tumor, malignant ovarian tumor, ectopic pregnancy, appendicitis, and diverticulitis. So on a clinical features, we can confuse with starting from pelvic infection, pelvic inflammatory disease till diverticulitis. It may confuse with the features of the endometriosis. Now, coming to the complications of the endometriosis, it can give rise to endocrinopathy. That is one of the commonest complications. There might be rupture of the chocolate cyst. Few 3 to 4 days back, I was showing married for 2 months, having severe pain abdomen or ultrasound, that is chocolate cyst. And on the OPD itself, I told that it could be a ruptured endometriotic cyst. But in contrary, in a dormant cyst of the ovary, the torsion is more important, wherein chocolate cyst of the ovary, this rupture is more important, more common, and which might be the one of the cause for pain in the abdomen. There might be infection, obstructive features might be there, intestinal obstruction might be there, so ureteral involvement and malignancy. Yeah, I must tell that whenever there is a malignant transformation, there are two forms of malignancy endometriosis can give rise to. One is endometrioid cancer, the other is clear cell carcinoma. Friends, you remember that the complicated malignant counterpart of endometriosis is number 1 endometrioid cancer, number 2 clear cell cancer. The endometrioid cancer can coexist with the ovarian lesion as well as in the endometrium, that is endometrioid cancer of the endometrium as well as endometrioid cancer of the ovary. So whenever they coexist each other, so most important is to diagnose the complications, malignant complication for a endometriosis. Now coming to the endocrinopathy, that in an endometriosis, to start with, there is corpus luteum insufficiency, because corpus luteum is not formed because of hyperestrogenic. Then there is increased PGF2 alpha luteolysis. It causes luteolysis by increased PGF2 alpha. Then luteinized unruptured follicle, because the follicle doesn't rupture. Subsequently, anovulation occur, and there is elevated prolactin level. There is hyperprolactinemia. So therefore, there is double LH peak instead of a single LH peak. In case of endometriotic lesion in a woman, there will be double LH peak. Now coming to the staging, that is very important. Why you stage the endometriosis? What is the need? Because to predict the prognosis, that is very important. To the best and to evaluate the treatment protocol. So therefore, friends, first is to choose therapy, and before choosing therapy, to evaluate the treatment protocol, which would be best for that patient, and lastly to predict the prognosis. Now most important is AFA scoring. If you see American fertility scoring system, it is the only scoring in case of endometriosis. This is a scoring for years together. So what are the advantage and disadvantage, I'll be telling, but before that, let me tell you shortly that the endometriotic lesion is classified according to whether it is a superficial or deep. Then 1, 2 according to the centimeter, 3 less than 3 centimeter, more than 3 centimeter, and superficial and deep, you see that either in the peritoneum, ovary, or either in the tube. So whenever the lesion is there in the ovary, the scoring system change either 2 or 4, 16 or 20 like that. And again, according to the adhesion, if the adhesion is filmy adhesion, right, left, then filmy adhesion of the tube, right, left, all these give score up to 1, 2, 3, 4 like that. And lastly, if the fimbriated end of the fallopian tube is completely enclosed, change the point assessment to 16. So you calculate, there are 4 stages, mainly minimal, mild, moderate, and severe. That is stage 1, 2, 3, 4. Stage 1 is known as minimal stage, that is 1 to 5. Stage 2 is mild, that is 6 to 5. And stage 3 is moderate, that is 16 to 40. And stage 4 is severe, that is more than 40. Now, limitation of the AFA scoring I was telling. So it is not a complete scoring system because there is no competitor scoring system so far. So you must know what are the limitation of it. So what are the disadvantages of it? So always for the AFA scoring in endometriosis, either you have to go for a laparoscopy or a laparotomy. That means externally, unlike in a cancer cervix, by clinical examination, you can tell that, yes, this is the clinical staging. So, and next is inter-observer and intra-observer variation. I'll say that the ovarian lesion is 3 centimeter. Next day, the other person is doing in the same day. So he'll be telling it is 3.5 centimeter. So this is known as inter-observer. Whereas intra-observer, today I do a laparoscope, I'll say that 3 centimeter. Tomorrow I am doing same patient, that I may tell that 3.5 centimeter. So therefore, this is not a constant, because exact measurement we are not taking, we are just thinking. Now, extent of disease versus degree of symptoms. Now, how much it has progressed, we cannot know. And staging versus fertility outcome, we cannot tell that the stage 3 endometriosis, the prognosis for outcome for a fertility purpose is might be more than that of stage 1. So therefore, the staging has no relation with fertility outcome. Now, staging versus optimum mode of therapy. Now, if you stage that stage 1 having the result in the form of result, stage 3 might be having better result than that of stage 1. So therefore, with this limitation, we are in search of another scoring system. Now, coming to the treatment, either you can go for a preventive or a curative one. So let us see the preventive one. So avoid tubal patency test during menstrual cycle and DNC. So during the menstrual cycle, don't do the DNC and the tubal patency test. So therefore, tubal patency in the form of HSG or by the diagnostic hysterolaparoscope DHL, usually menstrual period we avoid. A post-menstrual, in the dry phase we do 8, 9, 10 day. Now, for speculum and PV examination should be discouraged, should not be done during the menstruation period, because it will precipitate the retrograde implantation. And avoid delayed marriage. So the woman or the girl must have marriage in a prime time. We call prime reproductive time. It should not be delayed. If at all delayed, you should not postpone the pregnancy. Plan for a later on pregnancy should be avoided. Now, coming to the curative, what is the objective? The objective is to abolish pain and dyspareunia. That is the symptoms. If there is symptom in the form of a pain or dyspareunia, you alleviate that, you make a treatment for that, and to improve the fertility. Fertility, that majority of the patient they come with infertility with the endometriosis, and to prevent the recurrence. You treat, chance of recurrence is more with the endometriosis. Now, factors influencing the treatment, what factors? Now, asymptomatic in good number of cases, that is the problem. Majority of cases are not. Subjective symptoms are not proportionate to objective signs. That is very important. Now, suppose there is severe pain, but the lesion is stage 1. There is no pain, but the lesion is stage 4. So these are the problem. Therefore, the subjective symptoms are not proportionate to objective signs. Then frequent association with infertility. So if you see that majority of are associated with infertility, and remission during pregnancy and menopause. That is the peculiarity of the endometriosis. Once the pregnancy occurs, there is remission of the disease. And once the menopause occurs, automatically the lesion regresses. The stage 4 becomes stage 2. Now, determinants of the treatment option, which will modify the treatment for the endometriosis. Number 1 is, if she is young age and old age, the treatment option, the same candidate, if she is at a 20 years present with endometriosis, treat differently. Another 40 years, completed family, I'll treat differently. Now, size and extent of the lesion determine the treatment option. Severity of the symptoms, obviously, the patient has come for symptom, not for the disease, endometriosis. So I'll treat the symptoms. And the location, if it is in the ovary, I'll treat separately. If it is in the rectovaginal nodule, I'll set separately. Now, desire for fertility, results of previous therapy, whether she has been treated by earlier gynecologist with the infertility and endometriosis or not. If at all treated, that I must refer and treat accordingly. So therefore, these 5 factors will determine the treatment option. With these, what are the treatment options with us? The first is expectant treatment. The second is medical therapy. The third is surgery and combined one. So with this, now let us see what is the expectant treatment available with us for endometriosis. First is case selection. Most important is case selection. Minimal endometriosis with no other abnormal finding. Let us say only there is a small powder bone appearance. That is stage 1, less than stage 1. Unmarried girl, young married, ready to start family and approaching menopause. These are the cases you just give symptomatic treatment or expectant treatment. Don't do anything. Encourage, counsel, change the lifestyle. You will get fantastic result. Now, protocol for expectant management is NSAID, that is painkiller, then PG synthetase inhibitor, I to 1200 milligram daily, meflomic acid 150 to 600 milligram daily, or married women encourage for. So therefore, friends, it is the only expectant means it is the anti-inflammatory and counseling, that is you encourage for early pregnancy. Now coming to the hormonal treatment, aim, what is the aim? Induce atrophy of the endometriotic implants, suppressive rather than curative. You suppress the endometrium because that's why you can suppress the lesion for the time being. Now you see the drugs. What are the drugs available with us? The combined OC pill, COC. So you can go in it causes pseudo pregnancy. These are well tolerated, but the only thing, it depends on the fertility, what is the obstetric status, what is the age of the patient. Then coming to the progesterone alone, the available with us are medroxyprogesterone acetate MPA, dydrogesterone acetate, or norethistran. So this can be given orally, or medroxyprogesterone acetate can be given injectable in the form of intramuscular 150 milligram at 3-month interval for at least. Remember, it also causes pseudo pregnancy. Often we ask that COC causes pseudo pregnancy or pseudomenopause. It causes pseudo pregnancy because it suppresses the endometrium. It doesn't destroy the endometrium. And again, similarly, suppresses the endometrium. Now coming to the IUCD, that LNG IUS system, that is levonorgestrel intrauterine system, it again causes the pseudo pregnancy, that you can give the progesterone impregnated copper T. So danazol, as you know, this causes pseudomenopause. Earlier we were using 400 to 800 milligram in heavy doses, but it was less tolerated. So today in the modern gynecology, COC are quite often tolerated, then progesterone are tolerated, and IUCD is one of the beautiful drug. Then gestrinone, it also causes pseudomenopause. It is but well tolerated. What most important is the GnRH analog, that you can go for a leuprolide, neferolin, goserolin, and it causes medical oophorectomy. Remember, friends, the terminology is medical oophorectomy. So if you give GnRH analog, but it is well tolerated and is mostly prescribed drug for endometriosis, especially with the infertility. Now coming to the COC in short, very short, that it is cyclically used continuous fashion, advanced in young patients. For pregnancy, you must counsel that I don't want pregnancy during this time. It causes endometrial decidualization and atrophy, which I've told, suppresses, may induce amenorrhea at times, and but it relieves dysmenorrhea. So another is anastrozole, that is aromatase inhibitor, reduce growth and the pain also. In absence of the COC, you can use the anastrozole. Now coming to the progesterone, it causes decidualization, atrophy, high doses suppress ovulation, it induces amenorrhea, it can be given oral route, commonly used. Injection depot, I have told, not given who wants pregnancy. MPA, injectable medroxyprogesterone acetate. It causes anovulation, cheaper than the danazol, and progesterone antagonist like mifepristone 50 to 100 milligram can be given. So also there is a role of progesterone antagonist, and mifepristone is also upcoming for the endometriosis. Now coming to the LNG IUS, which is commonly used by the practitioner. So it relieves the dysmenorrhea, that is the most important. It relieves pelvic pain. Dyspareunia also is being relieved. It relieves menorrhagia. So it is the drug of choice for adenomyosis and for the rectovaginal endometriosis. Remember, friends, the COC, combined OC pill, progesterone are not effective in adenomyoma and a deep pelvic endometriosis like rectovaginal pelvic endometriosis. So therefore, the drug of choice is LNG, IUS in these cases. Then coming to the danazol, it's a 5th day, 600 to 800 milligram. It causes amenorrhea. It was as a barrier contraceptive you have to give. It causes virilization and resolutes up to 80%. Success rate is quite. Recurrence is 40%. But the side effects are intolerable. There will be hot flushes. There will be burning sensation. There is increased weight and it is costlier. The other drug, gestinon, side effects are less. It is given twice weekly. And most importantly, GnRH analog. It causes hyperestrogeny. It causes amenorrhea, reduces estrogen, and side effects are tolerable. But only thing, it is costly. At 28 days interval, if you are using for this leuprolide acetate 3.75 milligram intramuscular in the bottle at 28 interval for 3 cycles, you can continue. Then coming to the add-back therapy, if you give this, there is depletion and you go for a cyclical estrogen and progesterone therapy or alone estrogen therapy. This is known as add-back therapy. So whenever you are using, there is chance of estrogen depletion. So you have to supplement with the estrogen and progesterone or estrogen alone. The other medication like progesterone antagonist, mifepristone, it can be used. Then SPRM, selective progesterone receptor modulator like asoprisinil. Then Dynogest, synthetic progesterone I have told, which we have been using often, that is 2 milligram continuous fashion for 3 months. GnRH antagonist, that like cetrorelix 3 milligram subcutaneously. Aromatase inhibitors like anastrozole, which I have already told. And cell proliferation. Then rosiglitazone, it release of the pain. And lastly, that is upcoming drug in the world, elagolix, that is oral non-peptide GnRH antagonist. Perhaps this is the $1 million drug in the future. It will replace the GnRH almost for all practical purposes. If it comes to any market in any country, it will be the drug of choice for the future for the endometriosis. That is elagolix, oral non-peptide GnRH antagonist. Now, judgment of efficacy, how to judge that relief of symptom? The patient will have less symptom or no symptom. Reduction of the volume by the ultrasound. You go for a secondary laparoscopy, you see the lesion is decreased. That is improvement of the fertility. That is prevention of the recurrence. And no single treatment is best. You have to choose. It is a cafeteria choice. Patient is one side. All these choice of treatment are there in the cafeteria. You have to select 1, 2, 3 or combination. Now, no single treatment is the best. So therefore, and GnRH is most effective for symptom and volume so far. Now, coming to the surgical management in nutshell, that conservative management of surgery. In the laparoscope, I have told you desiccate or burn out the lesion. You can go for a cauterization. You can go for a laser vaporization. So in certain cases, that is CPP, chronic pelvic pain, you go for a LUNA, that is uterosacral nerve ablation, laparoscopic uterosacral nerve ablation. You can go for a excision if it is a larger lesion. Endometrioma, you can aspirate, but that is not recommended. You can vaporize. Most important is cystectomy. If at all we are going for a cystectomy, you try to strip out the capsule. Majority of the endometriosis, the capsule is not totally coming out. You cannot do complete separation of the capsule from the cyst. So therefore, in those cases, you may go for a cauterization of the base. Then definitive surgery, but you should not go for a overcoagulation because there is chance of premature ovarian failure. Especially for the infertility, you may not get adequate AFC or antral follicular count. Now coming to the definite surgery, whenever the patient has completed family, she is pious, elderly, so go for a hysterectomy with bilateral. So friends, remember here, hysterectomy alone may not be adequate. Last week we got 2 cases, 32 years, stage 4 pelvic endometriosis with bilateral cholecystosing ovary densely adhered to the lateral pelvic wall with the NDVH and bilateral salpingo-oophorectomy. Because of the vessel sealer matting, we could do it. Now, resection of the bowel and the bladder, at times, if those are involved, you take the help of the urologist or the GI surgeon friend. Now coming to the results, lap cystectomy, around 70% result success rate with pain is relief. In terms of pain, it gives release up to 74%. Now pregnancy rate is almost 60% in moderate, but 30%, 35% in severe, that is stage 4. Indication of definitive surgery, that no prospect for fertility improvement. So you cannot be improved. You counsel with the patient and you get the definite treatment. Other treatment have failed. She has been treated outside, almost failed, and completed family as a you go for a definitive surgery in the form of hysterectomy with bilateral sublimbar oophorectomy. Now, combined medical and surgical, that pre-operative hormonal therapy you can go, downstage the GG stage 4 to stage 3 by GNAS analog, go for the surgery. It controls the pain, does not improve fertility. Duration is around 3 to 6 months, and post-op pregnancy rate is 51%. 6% for stage 2, 45.5% for stage 3, and 44% for stage 4. So therefore, friends, as this disease advances, the prognosis for the prognosis is also after the treatment. Now, endometriotic at special sites, it can be at abdominal scar, it can be in the umbilicus per se, in the gut, bladder, ureter, cervix, vagina, and lungs. So accordingly, you have to treat. And most of the cases, whenever there is a distance endometriosis distance site outside abdominal cavity, it is all the time it is excision. Now, how do you manage this? You go for a medical management or excision. Like let us say there is a incision in the scar site, you have to excise. Incision in the arm, thigh, you have to excise those things. Now coming to the most important, that is endometriosis interna or adenomyosis. So you come to the definition that whenever the endometriotic lesion sits on the myometrium, it is known as adenomyosis. It can be either a diffuse or a local. So how do you know if it is only one side is affected? It's a local one, or it might be diffuse throughout the myometrium, all throughout, anterior, posterior, in the fundus, everywhere it is there, including the ischemic area. Now, what are the causes? As you know, repeated childbirth, the endometrium is being injured, and by any means, endometric tissue has entered inside the myometrium. If you do a vigorous curettage, excess of estrogen effect in general might cause adenomyosis per se, and pelvic endometriosis coexist around 40%. That means endometriosis interna and externa together coexist up to 40%. Now, what is the pathogenesis of adenomyosis? As stroma and gland both are situated there in the myometrium and grow, that is absence of submucous layer, that is very important. If you see layer is not there, there is disturbance of the normal junctional zone. Normal junctional zone is not there, and that is endometrial factor is there, and genetic predisposition. Most important in adenomyosis, it is seen perhaps the mother is having adenomyosis, and in the family it runs either sister or daughter. Now, altered immune response. Most important upcoming is perhaps the immune response is altered, therefore giving rise to adenomyosis. Now, coming to the pathology on the naked eye, you have seen diffuse symmetrical enlargement. On the cord section, you see thickening of the uterine wall. You can see on the cord section trabeculated appearance. No capsule is there, whereas in case of a myoma, there is a capsule. In adenomyoma, no definite capsule. Visible blood spot, and on the histopathology, you find stroma in the gland. Now, clinical feature very shortly, majority cases are asymptomatic, almost 1/3 of the cases. Patient profile is parous, middle aged, around 80%, 35, 37. Symptoms, there is menorrhagia, 70%, and dysmenorrhea up to 30%, and dyspareunia and polyuria. But it can cause infertility. So abnormal, why infertility is caused in adenomyosis? Because of the abnormal function of the subendometrial myometrium. And there is retrograde myometrial contraction is there because of the endometriosis. It is affected, so that the transfer of this, it affects the transfer of the sperm. So interference in sperm transport because of the retrograde myometrial contraction, that is a defective one. And defect in the implantation, so therefore it is unstable. This junction is not there, and abnormal endometrial immune response, because of that infertility occurs. And lastly, Perhaps there is abnormal nitric oxide level because of the adenomyosis. So all these factors give rise to infertility. Now coming to the signs, there might be it is more than 12 weeks hypogastric mass, but conventionally usually 12, 14, 10 weeks like that. Per speculum uniform enlargement. PV uterus is bulky, at times restricted mobility associated with fibroid or pelvic endometriosis. You can see it may confuse you with fibroid uterus. On laparotomy or a laparoscopy, you find that this is adenomyoma. Ultrasound, most important of a adenomyosis. For a postgraduate also, that subendometrial hypoechoic zone. Heterogeneous echogenicity, hypo and hypoechoic areas are there. You can see there is hypoechoic myometrium. There is multiple small cysts in myo. These are called honeycomb appearance because of the small cyst and increased vascularity in the myometrium. Ill-defined endoecho might be there. And on the MRI, it is the diagnostic. Low signal intensity junctional zone less than 8 millimeter exclude the disease. But junctional zone thickness more than 12 millimeter, that is very important. It suggests adenomyosis. Again, I repeat, MRI, if it shows the junctional zone thickness is more than 12 millimeter, perhaps she is suffering from adenomyosis. Now, coming to the management of the adenomyosis alone, you go for a NSAID, that's expectant. You go for a hormonal therapy, it has got little space, no scope. You go progestin, COC, little benefit. And LNGIS, really it controls the menorrhagia and dysmenorrhea. It is the preferred drug. And you can go for a danazol. But most important is the surgical management, that is definite one. Conservative adenomyomectomy by laparotomy or the laparoscopy. Then uterine artery embolization is the upcoming treatment for adenomyosis. And last but not the least, whenever she has completed family, she is a parous woman, middle age, 30, more than 35, 40. So you go for a hysterectomy. Now, lastly, I'll tell that I have completed almost. So how it is enigma? You see, till the treatment, starting from the definition, understanding of the disease, that is pathogenesis, histopathology, clinical presentation, and management, optimal management, both endometriotic, external and internal, is enigma. It still remains an enigma, and it gives an inquisitiveness amongst all of us, including me and you, all the postgraduates, all the specialists, those who are practicing. Perhaps you will discover this. So therefore, friends, God has a great plan for you. You are loved, you have purpose, you are masterpiece, you are wonderful made. So friends, never lost. The best is yet to come. So in this way, perhaps you will discover what is the exact definition, what is the exact cause of the endometriosis. So therefore, it remains, endometriosis remains an enigma for all of us. Thank you very much for patient hearing. Again, happy Teachers Day to all of you. Thank you.
Yeah, thank you so much, sir. It was really wonderful session.
Yeah.
Thank you, sir. Thank you. And it has been an engrossing presentation, absolutely. And I'm sure this presentation, we will ensure that it reaches to as many doctors as possible, even after the program, that we'll have a plan, because once one hears this, one gets a overview, in-depth analysis of what is actually endometriosis, basically. Thank you, sir. Thank you once again for getting this program going. And I am sure together we can make it a great success. Thank you very much, sir.
But Subhajit, I must tell you that I am overwhelmed with especially for the effort you have done. And especially Subhajit, under your leadership, Pratik, all of you have included Sanjay, all entire team of our communities, Harmonica, you have toiled. And I am really happy that you have in constant so much lovely touch with the great people, starting from P. Simapatra, Narendra Malhotra, this Hema Dibakar, Pratap Kumar, as well as Rishikesh, and entire team, our postgraduate, all the specialists across the country, all are really, we express heartfelt thanks, especially from poor of our heart on this auspicious Teachers Day. You are like a really brother in the need time. Thank you so much.
Thank
you so much, sir.
Thank you so
Okay,
much.
thank you,
And
Pratik. and
Yeah,
thank
yeah,
you.
yes,
Thank
sir.
you. Once again, happy Teachers Day.
Thank you so much. Thank you.
Happy
You are
Teachers
lucky.
Day.
You are like a family member.
Thank you.
so much.
Thank you.
Okay.
Sir,
Thank
sir,
you.
I will share the recording link with you, sir, by
Yeah.
tomorrow.
Okay. Okay. So nice.
Okay. Yeah. Yes.
Okay.
Thank you, sir. Bye. Good.
Thank you.
Thank you.
Thank you.
Bye.
Bye.